Hi, Rebecca.
Hi, Josh.
Welcome, everybody, to Managing the Adult Airway,
Part one.
Part Uno.
All right, let's jump right in. Airway first. This is what we've learned from EMT Basic. We understand that it is a priority with all of our patients, and most of our patients don't need management, but it is the one thing that we do most frequently to save lives. We will manage an airway and save a life in the field. So it's the first step in the primary assessment, and we need to have some considerations because as the medics on scene, at least in ground transport, you're kind of considered the airway expert. When we work in a critical care interfacility format, we need to look at the patient presentation and their airway prior to getting them into our transport unit, whatever that is, if it's a rotor wing or an ambulance, because we want to choose the most controlled environment to manage an airway. So if that means we come into the ER and make a quick assessment and decide that this patient needs to be RSI'd now before we leave, that's something that should be considered. We also could make a plan for if things go south, but we will talk about that as we move forward.
Yeah, we want to be really aggressive in airway management, and especially in interfacility transport, in that if you think this airway might go south and you're in the ER, getting ready to leave, it's always better to do it in the ER where you have more resources, more people, better lighting, more space, everything, than in the back of the helicopter or in the back of your ambulance. Now, that being said, if you're on a scene flight and say you have a traumatically injured patient that's critical and they are breathing, but they meet the
requirements, criteria.
The criteria to be intubated, using RSI, that doesn't mean that you're going to sit in the back of the ambulance and RSI him before you take him to the helicopter, or you sit on the side of the road before you put him in the ambulance and go. You go. If they aspirate because you didn't get to it in time, but you're moving towards the hospital, sometimes that's the best thing. Like they'll buy some extra time in the ICU, but as with all trauma patients, it's always a load and go.
They need bright lights and cold steel.
Yeah.
And probably blood.
Yeah. But in the ER where you have an option, you've got time, do a good assessment and
manage it early.
Yeah, manage it early rather than later.
All right. So with our airway assessment, it's going to be an assessment of patency and an assessment of protection. And these are overlapping concepts, but they are different. So patency is a free flow of unobstructed air. And we're asking ourselves, is this patient able to maintain their patency if they have it? So is there LOC such that they can do that? Are there secretions that we need to manage? Blood in the airway or blood in the mouth that we need to manage? Blood in their nose? Gastric contents, have they been vomiting? Are they going to continue vomiting? Swelling, is there a foreign body? Those are all things that affect the free flow of air. Now, airway protection is the patient's active defense against anything entering the glottic opening that's not supposed to be there.
I like to call it the air hole.
The air hole.
Thanks to an amazing anesthesiologist I worked with once.
Well, I think it's great. It is the air hole. So
you could also use that as a derogatory term. A-hole. And they're like, my wife would be like, duh. And I'm like, no, air hole. I was calling them air hole. They're important. Listen here, you little a-hole. Why are you talking to our children like that? Because they're important. They're critical to our happiness, and I love them. That's why I call them an a-hole.
Because without them, we'd all die.
Yeah. That's why I call everyone an a-hole.
So with airway protection, we have some key protective reflexes, and those are things like coughing, sneezing, swallowing, laryngeal closure, or what they call the adductor reflex. We could go on, but really what they've found for patient assessment is the best predictor of the patient's ability to protect their airway is, can they cough or swallow on command? And so it's not just if they can phonate clearly. if they can talk clearly and they're alert and oriented, odds are all of those reflexes are intact. But some providers will say, well, they're talking, so they have all their protective reflexes. And we know that you can have strokes that affect your ability to swallow because of those nerves involved, or your ability to cough, and they could still talk. So we need to be just proactive in assessing, do they have that ability? Will they be able to do that in the event that something tries to enter their glottic opening?
Also, the big one is gag reflex. Like we love to say, oh, they have a gag reflex, they can protect their airway. Not necessarily.
Not necessarily.
Now, if you haven't learned, because, you know, mostly ground paramedics, we intubate people who are mostly dead, maybe nearly all dead.
If you haven't seen The Princess Bride.
But now, as you move forward to critical care, you will be taking people who are breathing and making it, taking their airway, making it so they can't breathe on their own, right? And so you have a lot more options with airway management. And so gag reflex, you just have to understand, just because they have a gag reflex does not mean that they can protect their airway. Secondly, don't check for a gag reflex. Like stick your finger in there?
They put like an OPA. And the thing with the gag reflex, think of that reflex as like the last ditch effort for your body. It's like everything else is gone.
Reflex.
So that's not what we should be relying on. So coughing and swallowing on command.
And then I just wanted to make sure that people are aware, like, an OPA or an NPA will maintain airway patency, but does not protect the airway, right? Versus an endotracheal tube, which is really the only thing that we can use to actually protect their airway for them.
Everything else is just patency.
Yep.
That's a good distinction. Okay, airway assessment includes looking for teeth, dentures, anything that might be in there, or it just might be their tongue. Do they have stridor? Is there swelling? Is there some foreign body at the back of their throat? Angioedema, that falls under the swelling. And facial or neck trauma, we've all had those patients that seem to be managing it while they're sitting, but if we lay them flat because of the trauma to their face, we're suddenly going to have an airway issue. So that's a consideration. And dysphagia. Josh, how do you remember dysphagia versus dysphasia?
Oh, you actually gave me a good way yesterday. So dysphagia is difficult or inability or difficulty speaking. Dysphagia with a G is inability to swallow or difficulty swallowing. So S for speech, dysphasia, and dysphagia for, did you say gag reflex?
That's how I remember it.
I like it.
But that's specific to a cranial nerve. And so assessing that is important. Obesity, we have a large number of our patients.
Pun intended. Sorry.
At least where I work, it seems like a good majority of our patients fall into this obese category. And that presents problems with their airway, among other things. And then what are their aspiration risks, either currently or coming in the future during transport? Do they have a GI bleed? Have they been vomiting? Is there gastric insufflation? And that we think of often with just BVM. But if this patient just came up in the morning and called us first thing, and they've been on a BiPAP or a CPAP mask all night, that itself will inflate their stomach. And it's a consideration.
Tell me about it. I wear CPAP, unfortunately, at night. I'm considering suicide because I hate it, and then maybe I just don't want to be here anymore. But even this morning, I wake up, first thing is this burp. Long, long, long. And sometimes it makes it past your stomach, and then it starts coming out the other end. Or maybe that's what you ate. I don't know.
I just know that that's a consideration that most providers forget, is that if they are on it during the night and you go in the morning, that might be a thing. If you're putting them on it during transport, you need to consider that, because it just forces air in.
Yeah.
So it's going to go the path of least resistance.
So the way you get rid of that is you just kind of prop them up over your shoulder and just with the little spit cloth on your shoulder and just pat their back.
Yep.
And just burp them.
Yep. Just if you can
That's
do
how I do
that,
it.
you're a superhero. All right. Part of our primary assessment then also includes circulation and disability. Circulation, I see a lot of new providers that are just super reliant on the numbers that are coming up from their monitor. I would challenge everyone to do a really good physical assessment of this patient's circulation. Do you check radial pulses when you first approach the patient? Are you looking at their general skin tone and color? Do they have good cap refill? All of those things we can do before we get our monitor on.
Right. And I just want to point out, I actually made this slide a long time ago, but we're going through the primary assessment, A, B, C, D, E, and everything in A, in B, in C, in D that applies to airway breathing, really. Mm-hmm. So like right now we're talking about skin color, right? That may be telling us about their oxygenation status. Mm-hmm. So we're not going to dive deep into a primary assessment, but what parts of circulation give us a look into what's going on with their oxygenation and that sort of thing.
Right. Like disability, our brain is the organ that uses the most oxygen and the most sugar, by the way. But like when I have someone who's altered, my first check is, are they oxygenating? Because I can usually fix that pretty quickly. And then I check if they have glucose. And then do they have a blood pressure to get that to their brain? But if they are altered, we need to rule out hypoxia right away.
Right. And also, altered level of consciousness, can they protect their airway, right?
Right. Intubation is about work of breathing and mental status, not so much numbers.
Right.
All right. And then we're to expose. Visualizing their chest and their neck and their mouth when you're assessing them is super important. Do they have JVD? Is there symmetry in their anatomy? Are there signs of trauma to their chest? And I feel like that's pretty obvious, but I've had patients that have had very small penetrating trauma that we didn't pick up on right away because it's very small and it's not bleeding. It's just a puncture wound into their chest. So that really do a good, thorough assessment of their chest and anything affecting their breathing.
I remember one time we had this guy and he was really struggling to breathe, and I immediately just ripped his shirt off, and my partner was like looking at me like, what are you doing? And I mean, he looked like he was about to stop breathing, right? And his whole right side of his chest, sub-Q air, right? If I hadn't exposed him,
you wouldn't have known.
I wouldn't have known.
Right. And that's where palpation, we got to put our hands on, looking for tenderness, deformity, movement that shouldn't be there, crepitus, subcutaneous emphysema, any of that. And then percussion. I know this is not something that's normally taught in just regular medic school, but percussion.
I think my mic's having a pneumo tension.
Because if you are not familiar with the tones of percussion, that's something to work on, because we have a lot of patients. You can always kind of practice and hear what sounds normal, and you'll recognize when it is not.
Yeah, because when Armageddon happens and you don't have any medical equipment, and you're not a doctor, but you're the closest thing to a doctor, and your tribe has made you the doctor. Now you're going to be like, dang it, I wish I'd done more percussion.
But dullness indicates fluid. Hyperresonance may indicate a free space or air. So keep that in mind. That's something to practice. The primary assessment, we're just going to briefly talk about the focused adjuncts that we can use. And most of this will be stuff we get when we pick up an interfacility. Do they have a chest x-ray? If they have a chest x-ray, especially if they're intubated, we want to see that, because where's the tube? How does that look? How do their lungs look? A head CT, laboratory data, a blood gas, if they have it, is super helpful, especially if you work on an agency that has an I-stat and you'll be taking a venous gas in transit, then you have a trend to compare. And that's, I feel like, so important on our ventilated patients to manage. Capnography, ECG, all of those things help us assess the whole patient, but also how they're oxygenating. So in our secondary assessment is the history of their illness, their chief complaint. It's the OPQRST acronym that we've all learned. And I feel like we're pretty good at this on a 911 scene. But what I think we need to emphasize is when you pick a patient up in the setting of an interfacility, you still want to make an effort to assess this patient's chief complaint and their history of their present illness. I always try to ask, how were they brought in to the emergency department? What has been their trends? I want to see all their trends. I want to talk to the patient if possible and find out how they're feeling. History of their allergies and meds and all of those things that we kind of already know from our 911, I think is still very applicable before I take a patient with me for an hour or so in the back of an ambulance. Because if I take this patient without doing my due diligence to know this, then I have set myself up for a problem. So,
and I want you listeners out there to be thinking, like right now, if you've never done critical care transport, you've got to listen to this in that context. This isn't just in the context of you running 911 calls. This is you at the hospital,
yes,
talking to the nurse. I know, I don't know about you, Rebecca, but at the agency that I work at right now for ground transport, they don't give us anything. But when I fly, I get a novel of all their paperwork, all their test results, their ER doctors, their whole ER notes, like telling everything, right? Their lab results, everything you get. And so you kind of have to balance on your secondary assessment, like, yes, get this stuff, especially relating to airway and stuff like that. But also know you will have access, although sometimes you get in and you're like, oh my gosh, they didn't give me the one
thing I
needed, right? So you do your best, but at the same time, these are usually sick patients. You're moving forward with them. But you do have paperwork to give you a lot of this stuff as well.
I ask for it because I work in an agency where we run 911 critical care, but we also take the critical care interfacilities. And if they haven't given me the full package, I just ask for it and it just professionally, but
plus,
I want to
gives you something to do in the back.
Absolutely. My partners kind of tease me about it, but also I will say with that, I've noticed that sometimes when the staff at the ER is rushing me to get out the door, I then know I need to take an extra time to assess and make sure that everything's cool with this patient, because in my experience, it's meant that the patient is trying to die and they're just like, get them out of here. And I want to be time sensitive, but I also have a limited resource in the back of my ambulance, and I want to make sure I manage any problems beforehand. So that's just been my experience.
Quick story. So one time we're flying this patient, it's during COVID, right? And everyone's trying to get rid of their patients and no one's wanting to take patients. And this doctor gave us a quick, report and basically told us and the receiving doctor to where we were taking this patient only the things that he knew would get him accepted to that hospital. He also happened to be a trauma patient. We get in the back. I start looking through his paperwork. I'm looking at his rate. He had a C-spine fracture that they didn't mention. He had all these other problems. And so we're like, oh, geez, we didn't even know. And we get to the hospital, the receiving, and I tell the doc, hey, this is what we were told. Looking through his paperwork, here's what I've found. And he just rolls his eyes and he's like, yeah, they do this all the time. So we take the patient.
It is part
Funny
of being
story.
a patient advocate to thoroughly assess their trend while they were at the facility you're picking them up from. So moving on. As far as differentials, we are just touching on this slide because that is what makes you a good provider, is ruling out the differentials that could be there. And when you have a respiratory problem and a problem that you might need to manage their airway, look at all of these things. And I don't feel like we need to go into each one of these, but just so you know, your differentials do hold a lot of weight and they are important.
And when you are going out to like these rural facilities and things, and you get dispatched for a certain problem, you get there and you may find something while assessing this patient that was missed by the sending facility, or something that they didn't have when they were doing their assessment, but they've kind of just put them in the back room waiting for you, and now something's developed, right? So, or they found what they thought was the problem, and now you find a major secondary problem. So it's very important in critical care to be doing your differential diagnosis, especially, again, because if you don't catch something and then airway goes south en route, now you've got a crash airway.
And it's not that you're questioning the physician, the sending physician. It's more that you're part of the team. I think everyone should consider themselves part of this patient care team, and that you have to make an effort to cover all of your bases before you are alone with this patient for an extended period of time. Now, as far as our desired outcomes, I feel like I teach this when I teach in the paramedic programs and things like that. Any intervention that you make, you should have a desired outcome in mind. You shouldn't just be throwing interventions at a patient and being like, oh, well, we're supposed to do this next. We're supposed to do this next. No, if I put oxygen on a patient, I have in my head what I want to see change beforehand and what I'm going to do if it doesn't. What's my next level that I'm going to take it to? And so, is it improved skin color? Is it improved saturation? Is their end tidal going to improve with ventilation? Their LOC, like all of those things, have that in mind and have a plan for what you're going to do if it doesn't improve.
You're going to have to report on it anyways when you get to the receiving. Here's what we did. Here's how they responded. So rather than at the very end, right before you get there, clean up and just like, all right, what have they gotten better since we did all this? Okay, they're good. All right, let's give a report and go.
I make a tongue-in-cheek joke when I take patients, regardless interfacility or 911, but I'm always like, let's try to deliver them in better shape than we found them. And for the love, let's not make them worse.
Yeah.
That's my goal. All right, basic airway interventions. Prior to any interventions, you're going to put on your PPE, and we don't need to go into that because everyone has their own policy, but we will say follow your policies. Consider any spinal trauma, just like the story that Josh shared. Having a neck fracture can really change the way you manage an airway. And then clearing their airway, suctioning, repositioning. I took a patient not very long ago who was an aspiration. He had an aspiration event during a procedure because he wasn't intubated. And he was just producing a lot of mucus and phlegm because he got gastric contents in his lungs. So I just gave him the Yonker.
It burns. It burns.
I gave him, it was actually the Ducanto. I gave him that and he just suctioned his own mouth out while he was going down the road because he didn't need me to do it. He did need to be upright though to manage that. So have those things kind of dialed in. And then oxygenation, be aware of how this patient is oxygenating right now with what supplements they have and what you could do to enhance their oxygenation. And we all have used nasal cannulas. If your agency doesn't use a high flow device, they are fantastic. I find them super easy and very effective at oxygenating patients.
Yeah, they made a big entrance during COVID, and all of a sudden, which you hate transporting patients on BiPAP because there's all this air leaking around and you run out of oxygen really fast because there's so much leaking. And then all of a sudden they're using these high flow nasal cannulas, and we started carrying them at that point, and big difference. They're when they're appropriate, they are fantastic.
They're great.
Life-saving.
I 100% agree. And then just for your reference, know the difference between a non-rebreather and a simple face mask, and kind of the oxygen that they can deliver. Know what a Venturi principle and a Venturi mask is. Those are really kind of old school. I haven't seen one in years.
I've seen them at like a long-term acute care facility.
Yes, because they want to control how much oxygen the patient is getting through the mask, and so they have different things they put on to that change it's the Venturi effect, just like when we use foam at the fire department. And for those of you who aren't firefighters, that's just another way we put out fires, is use a soapy foam. But it uses that, it entrains air along with the oxygen and creates a mixture. So knowing that for your test is important. All right, a BVM. This is super important. This skill, I find people treat it as if it's just a BVM, but really it does take skill. And you need to be aware of how it feels. Are you putting just the right amount of air in? High flow O2 with a good seal, like you're going to get good FiO2 if you have a good seal. End tidal, you can use that with just a BVM, but just understand you've got a little more dead space. It is going to affect your number. But you can at least look at your waveform and see what kind of breaths you're delivering. Building up the bag, that it means like you're going to put your manometer, you're going to put your PEEP valve. Make sure some have it all built in, but just make sure you've got all of the appropriate things on the bag but when you start. And then the super plug, there's been a little debate about this, but I still use it. 2 NPAs and an OPA. I've seen providers do this aggressively, and we need to remember that our patients' nasal their nasal passages are very vascular. And if you
did you just put in a 49 French NPA into that guy?
It fit. I just think if we create bleeding, we're going to have more of an issue. So just be gentle, size it appropriately, and use some lube. Remember, it goes straight into the face and not up. Like it doesn't.
Not the way you pick your nose, right?
It doesn't go to where the eyeball. It goes like straight back to
almost
toward the
downward
ear.
even.
Yeah, kind of. Just that's the path that it should follow. So if you've never learned that, or had the opportunity to really tell the difference when you insert it, just know it goes straight in. And then elevating the head of the bed, that can help with oxygenation.
A lot,
yeah.
Pulls way up so that their heavy, obese chest isn't sitting, gravity helps keep the gastric contents down there where they need to be.
Yes.
Big time positioning is very helpful for oxygenation.
Yes. Our extraglottic devices, we're going to go over these. I think everyone's kind of transitioned to just the eye gels, but we're going to cover all of them. Josh and I have been around to see all of the different.
We'll be fast.
We'll be fast. Just remember that you still have an aspiration risk with all of these. They are just maintaining patency. They are contraindicated with a gag reflex. We will talk about each of them independently. So the single lumen extraglottic airway device. Did you use the King Airways a lot?
Yeah, we did. When they first came out, it was like magic. Like, oh,
they
my
were
gosh,
so good.
easy.
Yeah. I never had one not seat properly or pop out, because I've heard of that during like CPR and stuff. But that is something that I've heard happening. They have 2 balloons, and they kind of are supposed to plug up the esophagus and leave just one channel to go into the trachea. But they are not a definitive airway. The dual lumen airway, these are old school. I've
never even seen one, even in paramedic school back in 01.
Yeah, these are
they
old
showed
school.
them to us on a slide, and I still haven't seen one.
Yeah, so just know that that's a thing. With our LMAs, just remember that the IPAP, the inspiratory pressure, cannot exceed 20 centimeters of water in pressure, and that's what will pop it off of the airway. So if you're dealing with trying to, I think of it when you're trying to ventilate on the uptick of a CPR call, you're going to have chest pressure coming back, and it's probably going to pop your seal. So just keep that in mind. The same for the iGel. I know most agencies have kind of transitioned to these because they don't have a cuff that you have to inflate. It's a gel that is basically the heat of your body helps conform it to your glottic opening. And they're easy, they're fast, they have a built-in bite block. There's so many things that are great, but they are still not definitive. And your inspiratory pressure cannot exceed 30 centimeters of water. So again, in a situation where you're trying to put a breath in on the uptick of a CPR stroke, you will probably exceed that without realizing it, and it will pop the seal. It will not just send it to the stomach, it's going to pop it off of the glottic opening.
I'm a big fan of using these to oxygenate the patient before I intubate,
yes,
if they are, dead enough.
You have been the one that kind of brought me over to that side.
Because they're just as easy to put in as an OPA, really.
Right, and they're like a BVM but placed on the glottic opening.
Yeah, it's taking that mask, instead of having it on the face, you take that mask and put it right over the airway. So
I'm a believer now, Josh.
There are no studies to back up. That's just my personal preference.
Right. I love it. All right, this is something I've never done this. I've seen a couple of failed attempts. That's about it. But a nasal intubation, there are situations where it might be appropriate if the oral cavity is not available. Like if they've got their jaw wired shut, well, that might be the one we have to do this. If RSI is not an option, like your scope of practice doesn't permit it, and especially if you are seeing a predicted airway problem coming. Seizure, those are all things that are listed. Contraindications would be apnea, because the device we use to place it requires them to be breathing. And their glottic or their vocal cords will be open during respiratory exhalation. So we need to know that.
Yeah, they have to be breathing. I know of, this happened not too long ago. I won't name the agency or anything to identify, but this crew was working this person who turns out was definitely more on the dead side.
Yeah, they were riggered.
Pretty much, and met the criteria for failed airway, right? Which we're going to talk about because their jaw was
shut tight.
Yeah.
You generally don't have trismus after you've been dead a while. That's just rigor.
So this new paramedic was like, "We're going to RSI," and the old paramedic's like, "No, don't RSI. Just try nasal." And it was not spontaneously breathing, and they did try nasal. It didn't work, but it wasn't good. Anyways, they have to be breathing.
They have to be breathing, and
I have done one of these,
and
it was slick as snot.
See, I love
and
that.
So now I'm just like, oh, they must just be easy, but I hear they're not.
And you were using a BAM device.
Yeah, we had a BAM device. I just was looking at the situation, and this was for a ground agency, and I said, I was the engineer, I was driving the engine, and I just said, hey, you could try a nasal, and the paramedic just looks at me and I had the nasal, or I had the ET tube ready to hand it to him, right? And he's like, why don't you just do it? And I was already down at the patient's side because you don't do it from their head, right? And it ended up working really well.
I think that's great. The two that I've seen caused a lot of bleeding. And as I look back at those, I think that they were trying to put them in toward their eyeball. Instead of, like we talked about with the NPA, it almost goes toward like their earlobe. It's like straight back in. Mm-hmm. And a lot of lube, I think you need. And just know that you could create a lot of bleeding. And that was my experience in the ones that I've seen, is it created a lot of bleeding.
What is that part of the nose right at the top when you go up that bleeds?
not the turbinates. I don't know. I don't know.
Okay, it's Kisselbach's plexus, also known as Little's area. It's right there as you go up into the nose is this area with all this vasculature that will almost immediately start bleeding. That's where people tend to pick their nose, right? Anyways, it's an actual place, Little's area, Kisselbach's plexus.
Kisselbach's, how do you say it?
Kisselbach, like
Kisselbach.
Bach, like the musician Bach. Kisselbach's plexus. Must have been a German dude that found it. He's
Very
like
nice.
picking his nose. It started bleeding. He's like, oh, that is very good. The blood is coming from here. We will call it the Kisselbach's plexus. Jawohl. All right, let's go.
All right. The technique for, do you want to, since you've done this, would
What's
you walk through the technique?
Sure. So obviously pre-oxygenation is the biggest thing. Sometimes this is when people are going to this is they're trying to mask them. They can't. They don't have RSI as an option. But you tell them what you're going to do if they're conscious, obviously. Pick a nair. Look for the big one. Look at their septum. Like my son broke his nose a few years ago mountain biking, and his septum pokes over to the right. We realized like a year later because he's breathing really loud. Anyways, find the most open, wide open. Stick your finger, your pinky or something. Glove it. Put a glove on it. Stick it in there and just like you're
ream it out.
Yeah, you're literally you're dilating it. And you want to be at the patient's side, not up at their head, right? So
It's
you're
not like putting an ET tube in.
right,
Yeah.
right. You're at their side. Typically, you go a half to one size smaller than you would with oropharyngeal placement. They have these trigger tubes, which I've never seen one in real life. I've seen them on the videos where you pull on a little string. It's like a puppet. Curls it. Yeah. And then another thing, you're not measuring it at the teeth, right? You're measuring it at the nair. So it's going to be a lot deeper than it is when you go orally. So typically it'll be around 25 for women and 26 for men at the nair is where you'll measure the depthness. If you have phenylephrine, Afrin, that is a vasoconstrictor, which will reduce bleeding. Lubricate it generously. If you have some lidocaine, I'd put it on my finger.
Get it in there.
And get it up in there and get it numb. And then you put that, for us, we have the little BAM devices. I can't remember what that stands for, but as you get closer to the airway, you hear whistling because it's got a little hole on it. And so you can literally hear as you get closer.
When their vocal cords are open.
Yeah. You can also throw end-tidal CO2 on it.
Oh, that's a great idea.
Yeah. As you get close enough, you could start to get some waveforms anyways. And then once you're right there, as they take a breath, put it in.
Perfect. All right. Now, digital or tactile intubation. When a laryngoscope use is just not going to work. Like you're not going to be able to visualize anything. Cramped surroundings, limited access, or just equipment failure, you double glove and you get your finger back in there and try to figure out where the epiglottis is.
Yeah. I've never done it on a human. I've done it on the mannequins. Practice on your mannequins for this.
Get in there and just have an idea of what it should feel like maybe. Because I've never done this either. But
this is like one of those you're like in the car facing them perhaps.
And they're pinned and and you can't use the tomahawk like hold.
Yeah. It's like a last ditch effort.
Yes. Yeah. So that's all we're going to say about that. And then of course there's our standard endotracheal intubation, and we're going to dive pretty deep into this, but the indications would be apnea, altered mental status, elevated ICP, impending or potential airway compromise, and hemodynamic instability, but that comes with an asterisk because we're going to talk about that. Complications, hypoxia, unrecognized right main stem, unrecognized esophageal intubation.
That's a big one.
That'd be a bad day. That's a bad day. barotrauma, hemodynamic compromise, you might create hemodynamic compromise when you put a tube in someone. So we're going to talk about all of that. Just as a note, the errors associated with failed laryngoscopy that are on the side of the provider, they are rushed or frantic laryngoscopy, which when we talk about planning and getting everything like accounted for beforehand, that's what you're trying to avoid, is so you're not in a rushed, frantic situation. Laryngoscopy without a plan, like, you know, if you're operating like a cowboy, like could you
shoot from the hip. She was shooting from the hip,
shooting
folks.
from the hips. Yeah, like that is just not what we want to do when we're trying to manage an airway. Poor tongue control, and this is you're controlling the tongue of the patient. Legitimately, your blade is primarily there to control the tissue in their mouth so that you can see. And if you haven't assessed your ability to control their tongue, their area for displacement of the tongue, you are going to set yourself up for a difficult intubation. And then the fourth thing is poor ergonomics. The way that you're holding or handling your equipment, from the blade to your tube to the stylet or the bougie, all of those things play into not being successful. So we're going to go into those specifically.
All right, let's go ahead and stop there. That'll end managing the adult airway part
That's about
one.
all we can handle right now.
Yeah, we'll take a breath and start part two in a minute.